Well, welcome to the video for this week, which is on the cardiovascular system. The heart's located across the midline of the thoracic cavity. This is the standard anatomical position. So this is the right side and this is the left side. At the top of the heart, or superiorly, is the base of the heart, out of which the major blood vessels emerge, and the bottom of the heart, or inferiorly, is the apex. Now the pericardium is a sac in which the heart moves. It's made up of an outer layer called the parietal pericardium, an inner layer which is closely attached to the outer muscle layer of the heart called the visceral pericardium. And between the two is a space in which there's pericardial fluid, and this fluid allows those two surfaces to move against each other freely. Now the pericardium is attached superiorly to the pulmonary trunk, which becomes the arteries to the lungs. It's there, and then inferiorly to the diaphragm. So the pericardium is held firmly in place at the superior end and the inferior end, and between those it pumps within the pericardial sac. Now the pericardium is shown there. That's the outer layer, the fibrous pericardium, which is a tough fibrous layer, protects the heart. Inside that is the parietal layer, and against the heart wall is the visceral layer, or epicardium. And there you have the sac, the space in between with the pericardial fluid. And just going through the external anatomy of the heart, we've got the left ventricle, the right ventricle, above the left ventricle is the left atrium, above the right ventricle is the right atrium, and then we've got coronary vessels that cover the outside wall of the heart. I'll deal with those in more detail in a moment. We've got the aorta, is one of the major vessels emerging from the heart, and these are the three major vessels going to the head, neck and to the arm. Of course, the aorta supplies the tissues in the thoracic cavity, abdominal cavity, pelvic cavity and the legs. Blood returns to the heart via the inferior vena cava and the superior vena cava, which enter into the right atrium. Blood goes to the lungs from the heart via the pulmonary arteries, and returns from the lungs via the pulmonary veins. And looking at the inside of the heart, you have the left ventricle, the right ventricle. Above the left ventricle is the left atrium. Above the right ventricle is the right atrium. Between the atria and the ventricles are atrioventricular valves. And on the left side it's the bicuspid valve. It's got two parts to it, otherwise called the mitral valve. On the right side it's got three parts. It's called the tricuspid valve. In both cases, the valves are held in place by what's called chordae tendineae, which are then attached to papillary muscles which are part of the ventricular walls. And the purpose of both of those, the chordae tendineae and the papillary muscles, is to prevent blood going from the ventricle to the atria when the ventricles contract. So when the ventricles contract, the atrioventricular valves are closed, but they're prevented from opening up into the atria by the chordae tendineae. However, the semilunar valves in the pulmonary artery and in the aorta do open up when the ventricle contracts and allow blood to flow through those two blood vessels. Now, the muscle of the heart has its own external circulation. The arteries take off from the aorta soon after it leaves the heart, travel over the surface of the heart, and it receives all of its nutrients and oxygen from this source. It doesn't get any from blood that's internal to the heart. And veins return blood from the heart muscle to the junction of the inferior and superior vena cava. We'll just trace through systemic and pulmonary circulation. Systemic referring to the body, the whole of the body, pulmonary circulation referring to the lungs. So we start off with oxygen poor blood coming from capillary beds in the body, travels up via veins and the vena cava into the right atrium and then the right ventricles, and then out through pulmonary arteries up to the lungs, where carbon dioxide is released into the lungs and expired, and oxygen is added to the bloodstream, which then returns via the pulmonary veins as oxygenated blood into the left atrium and left ventricle, and then out through the aorta and the other vessels I mentioned into the capillary beds in the body. Now the heart goes through a cycle which starts with what's called diastole. This is when the ventricles are relaxed, and in that stage you're getting blood flowing from the atria into the ventricles through the atrioventricular valves, as shown in the diagram on the left. The next stage is where there's some contraction by the atria to force any remaining blood into the ventricles. Next phase is called ventricular systole, and what happens then is as the ventricles contract, they force the atrioventricular valves to close, but at that stage there's not enough pressure to open up the semilunar valves. So pressure builds up in the ventricles, but the volume in the ventricles doesn't change, and that's why it's called isovolumetric contraction. Eventually, pressure in the ventricles becomes high enough to open up the semilunar valves, so blood can then flows into the pulmonary artery and the aorta. And then we come to the final stage where this is in early diastole, where blood is flowing into the atria from the pulmonary veins and the vena cava. Now this cycle is shown in this animation very well, and there's a URL to this in your weekly materials. It shows the flow of blood through the heart, the various stages of the cycle. It shows the change in blood pressure and volume over time, the electrical signals produced in an electrocardiogram, and the heart sounds and when they occur. So you can go to this website and you can slow down the model and view it at your own speed and look at the tutorials and so on. Now, heart sounds are made by the valves closing. The lub is the atrioventricular valves closing. The dub is the semilunar valves closing. So this illustrates some of those sounds. This is a normal sound over the apex of the heart. And then you hear some abnormal sounds. And we go down to the aortic area. This is normal sounds. And the murmur, where the aorta diameter is closed. And then this is over the aortic area. We go up to the pulmonary artery area, normal sounds. Now you can go to that site and listen to those sounds. You only have to know the normal sounds, you don't have to know the abnormalities, but you may find them interesting. Now the heart by itself beats in an uncoordinated way. The atria beat at a different rate to the ventricles. So you need some way to achieve coordination between the two, and that's this system. And we start off with the sinoatrial node, or the pacemaker, and now this is has its own rhythm, own natural rhythm, but it's also influenced by the parasympathetic and the sympathetic nervous system, and also by hormones that are circulating in the blood. It sends a signal out to the left atrium, but also to the atrioventricular node. It then sends a signal down through the bundle, the atrioventricular bundle, which goes through the interventricular septum, the wall of muscle between the ventricles, and then spreads out via Purkinje fibres across the heart wall.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
Now we just explore those electrical signals in a little bit more detail. If you put some nodes on a chest wall, you can record these signals. This is an electrocardiogram or electrocardiograph, ECG. It's made up of the P wave, the QRS complex, and the T wave. The P wave is the sinoatrial node sending off a signal. The Q is the atrioventricular node sending off a signal, and then you've got the signal going down the bundle of His, which is the QRS complex, and then the signal passing through the Purkinje fibres, and that's the T wave. Now, this is used for diagnostic purposes, very commonly done to check for abnormalities of the heart. Now, cardiac output is the amount of blood that the heart pumps out in a certain period, in this case in a minute. And it's made up, CO stands for cardiac output, HR heart rate, and SV stroke volume. The normal heart rate is 75 beats per minute, so this is the resting heart rate. The stroke volume is the volume of blood ejected by the heart in each beat. So cardiac output for a minute is a bit over 5 litres. Gives you an idea of how much blood the heart moves over time. And this is at resting, so it increases quite a lot with exercise. And there's a good video that you can go to, which is in the learning materials, that goes into this in a lot more detail. But by way of summary, the factors influencing cardiac output is 1, the heart rate, and the primary influence there is parasympathetic and sympathetic nervous system, but also hormones have an effect there, adrenaline and noradrenaline. And then with stroke volume, a key factor is the amount of blood that's returning to the heart from the pulmonary veins and the inferior and superior vena cava. The greater the volume emptying into the heart, the greater the stroke volume. And again, the video that I referred to in your weekly materials explains that in a lot more detail. This is a diagram from your book, which looks at the factors in a bit more detail. In pink, we've got the stimuli that have an impact on cardiac output, including hormones. But notice that there's a negative feedback mechanism, that when these stimuli cease to be active, the heart goes back to normal output rate. So in green boxes is the physiological response of the heart to these stimuli. And these impact on stroke volume and heart rate, and together they influence cardiac output. Now this diagram shows another view or another aspect. It refers on this left column to bradycardia, which is lowered heart rate, which is affected by the amount of stimulus of baroreceptors in the aorta, carotid arteries and the heart. Now baroreceptors respond to blood pressure and are very sensitive to it. We'll talk about chemoreceptors when we go to the other column. And stretch receptors in the lungs refers to when you're exercising and breathing, your breathing rate increases, the stretch receptors are stimulated, and so they then have an effect on heart rate. Fear and grief can produce bradycardia, and also some hormones can produce bradycardia. Now going to the other column, tachycardia, increased heart rate. Again, if stimulus to the baroreceptors is reduced, then they're not so active. But this next part is quite important. Chemoreceptors are receptors that in various parts of the body that respond to changes in carbon dioxide and to pH or acidity of the blood. They also respond to the stretch receptors in the lungs, to excitement and pain, to hormones, and changes in temperature. And this is not just fever but increased temperature as well, which we'll cover when we get to the laboratory report. So that's all for this week. Thanks very much for watching.